Good evening, everyone. I welcome one and all to this Woolcock Memorial webinar. I would like to start by introducing Dr. Christine Jenkins. It's going to be very difficult to summarize all her achievements. She is a inspiring figure in the field of respiratory medicine. She is the professor of the University of in the Department of Respiratory Medicine and University of New South Wales in Sydney. Her main research interest is clinical management of airway diseases. She's also passionate about teaching. Another facet of her career is her major roles in advocacy and leadership in lung health, especially in Australia. She's been the chair of the Lung Foundation of Australia and has been a member of many panels, including the National Asthma Campaign. She has a long list of awards and honors. One of them was becoming the member of the Order of Australia for her service in the field of respiratory medicine. She's a member of many societies, and she's also a proud member of the American Thoracic Society. So I welcome her to this meeting.
Thank you so much, Dr. Baalachandran, and it's a pleasure to be here, and thank you for inviting me to speak to the audience today about one of the really great leaders in respiratory medicine, not just in Australia, but internationally, Professor Ann Woolcock. Ann was a mentor of mine. I didn't expect that to happen, and it happened in a rather unusual way, which I will explain. But she was also a great inspiration to many, many people who worked with her and who knew about her work and her accomplishments. She completed her university education at the University of Adelaide. She was really a budding student from a quite early age. She then went on to do a PhD under the supervision of Professor John Reid at the University of Sydney. John Reid was a leading respiratory physiologist, and he also helped her to set up a laboratory, a respiratory function laboratory at Royal Prince Alfred Hospital, which was quite an unusual thing at that time in the early 1960s. Anne actually then continued to do airway physiology studies, and the first of her 300 papers, which is quite a remarkable achievement for somebody who died in 2001, even before we knew about PDFs and digital papers and online information. The very first of those papers was the paper she submitted as part of her MD thesis, which was on the mechanical behavior of the lungs in asthma. And she described the phenomenon of pulmonary hyperinflation and gas trapping as it applied to small airways disease in asthma. And at the time, small airways disease was not really appreciated as a significant contributor to pulmonary hyperinflation. It was understood that large airways were the airways that really were affected in asthma, and the small airways were very unrecognized until that time. But you're going to hear more about that today, and I think it's most appropriate that Anne describe the behaviour of the lungs in acute severe asthma as in a physiological way, and you're going to hear more about the ways in which that has progressed now to be able to be seen and measured through pulmonary imaging. So, although Anne undertook more physiology, she actually moved into a much broader range of interests in asthma, in particular asthma epidemiology. And she was very interested in the relationship between genes and environment and the way in which that contributed to the inflammation of asthma. And again, it was quite remarkable that she thought about inflammation in asthma because, again, at that time, airways disease was really understood to be a consequence of abnormal smooth muscle behavior, and primarily something that related to the mechanical functions of the lung and not necessarily something that was driven by inflammation. The important thing about this is that she came to the conclusion that it was actually both inflammation and abnormal smooth muscle behavior, airway hyperresponsiveness in particular, that contributed to the development of asthma. And she was especially interested in allergic sensitization and the role of environmental allergens in the development of asthma in children. And she did a number of studies, starting off in Papua New Guinea, in the highlands of Papua New Guinea, where she went with her husband, Reuven Blackburn. Reuven was the Dean of Medicine in the Faculty of Sydney at the time. He was considerably older than her, but he actually outlived her. Reuven died at 102 just 7 years ago, and he himself was also a remarkable contributor to medicine in Australia. But they went into the New Guinea highlands, first of all, and documented the exposure that people living in huts in these very remote circumstances had blankets that were full of mites. And she described the role of house dust mites in provoking and triggering asthma in children, and the prevalence of asthma in these remote locations, which people would have considered were healthy in a sense, in that they were right away from all the sort of common airborne allergens that we have in our houses today, but they were not actually. Her work in epidemiology actually also described airway hyperresponsiveness in children in a number of different settings in Australia, across the country, from Busselton in Western Australia, which is as part of a long-term health study that had been set up there, but also in school children. She was able to do studies in children showing the likelihood of having asthma related not just to their allergic sensitization, but also to their family history and the history of atopy and allergy in their parents. She was extraordinarily busy by this stage in her career, but it didn't matter how busy she was in research. She had an international reputation that meant she was flying around the world and speaking at meetings. And despite those demands, she would always be back in Sydney. Often planes land in Sydney internationally around 6 a.m. in the morning, and Anne would be in her clinic at 9. And this dedication to looking after patients was really exceptional. And she truly, deeply believed that it was seeing patients that contributed to asking the right questions and then doing the research that she then related back to patient care. She was given a personal chair in the Department of Medicine at Royal Prince Alfred Hospital in 1984, at a time when women had negligible representation in the upper echelons of tertiary teaching, research and administration, and only 3% of professors in Australia were female. In 1989, she was awarded the Office of the Order of Australia, and she was elected a Fellow of the Australian Academy of Science in 1992, and she was the first practicing female clinician to earn this distinction. She was also an advocate. She was not just a clinician and a researcher and a teacher, but she was committed to promoting respiratory health in the Asia-Pacific region, and she was very active on many national and international scientific and public health committees. I'm just going to show you now a couple of slides of Anne and show you how she actually had mentors who some of you would recognize here. This is her graduating year in 1956 in Adelaide. Here she is in her second year of medicine. And then subsequently, this is John Reed in the top left. John Reed was a physiologist of great note. Some of you will recognise in the centre picture Professor Peter Macklem. Peter was a great teacher for Anne, and Anne spent time in Montreal with him in her postdoctoral period. And she came back to Australia and she had many PhD students, and one of them is Greg King. And Greg King's standing here. This would have been at the time that he was actually doing his MD thesis himself. And they were studying ways in which you could look at airway conductance and reactance, and using forced oscillometry to study the small airways, and Greg is actually an expert in small airways physiology and imaging, which Sarah's going to talk about later on. And then you see here Professor Peter Barnes, and Peter and Anne were great friends throughout Anne's life. One of Anne's favourite things to do was actually to hold research days. And in those research days, she would have a whiteboard absolutely covered in ideas, and she was very, very keen to involve people, even very junior people, in participating and in generating ideas, in thinking about ways of doing research studies. And these days would be exceptionally well attended, very, very lively, and really extremely productive. And they often generated ideas that people later took up in a number of different circumstances and undertook further research. My own experience with Anne initially was not particularly promising. I was doing my PhD and I submitted an abstract which she actually reviewed, and it came back with red marks all over it, which were her marks in showing just how she felt that my title was completely wrong. I had called it viral upper respiratory tract infections are not associated with increased airway hyperresponsiveness in non-asthmatic subjects. And she told me I should be saying normal airway responsiveness is preserved during viral respiratory tract infection in healthy young adults. I was very distressed about the multiple red marks, and but she reached out afterwards and we became very close, and initially professionally and then subsequently personally. I was 20 years younger than Anne, and this surprised me, but it's very much a sign of the way in which she associated with younger researchers, encouraged them, and really was an incredibly positive influence. Another thing she was exceptionally good at was looking at her presentations beforehand and putting forward images that were really quite unusual. And her slides really epitomise the skills she had in combining her imaginative sort of lateral thinking with her science. And she had, for instance, one of her slides in one of the presentations quite only a year or so before she died, was about the problem of high allergen sensitization in Australia. And this slide had an asthmatic airway on one side of it, and mites, a big picture of a blown up house dust mite, and a map of Australia. And on the other side was a pregnant woman, and overhead was an aeroplane which was on its ascent. And the pregnant lady was dashing through the departure gates to get it. But for those who appreciate that Australia is home to house dust mites airway sensitization, and that it starts at birth at the latest, the idea, if you wanted to maximise a baby's chance of not having asthma at that time, was to leave at conception. And this lady, unfortunately, was missing the plane. Her slides certainly did show remarkably some of her very important scientific concepts. And these slides just show you how she developed some of those. And you see here on the left how she described the asthma pendulum. And in the 1960s, we thought asthma was all about airway smooth muscle hypertrophy and hyperresponsiveness. But as the scientific understanding of asthma developed, we come through to the 70s and 80s, where she described it as being both inflammation and abnormal airway smooth muscle behaviour, and then subsequently how, in fact, it was the cells also that were driving both the manifestations of asthma, the clinical manifestations of airway hyperresponsiveness, as well as the airway smooth muscle. And she then began to think about the ways in which this meant we were able to target eosinophils and inflammatory cells, in particular with inhaled corticosteroids. And she undertook a number of studies that were absolutely essential to our understanding that short-acting beta agonists are not a treatment for asthma. They are simply a treatment that helps airway smooth muscle to relax and dilate the airways, but they are not a treatment that actually addresses the underlying cause of the disease. And a lovely slide of Ann's also shows the temporal relationship between starting inhaled steroids and the ways in which symptoms settle first. Then the FEV1 normalizes, the morning peak flow and diurnal variation normalize, and finally airway hyperresponsiveness normalizes. And that was a slide of Ann's that she actually created in 2001. Not long before she died, and it does represent the evolution of airway response to appropriate treatment with anti-inflammatories. This is just a portrait of Ann, which was made of her before her death, and I will finish there because we had a hard time in the Institute of Respiratory Medicine, which she had founded, which is really now an eminent institution named after her death. It was named the Woolcock Institute of Medical Research, and it's become an institute of very important contribution to respiratory medicine in Australia. And this portrait, we could not persuade Ann to have her portrait done. She finally sat for the portrait on one occasion, and the artist had to take photographs and then complete the portrait without Ann's help. But she finished it before Ann died, and Ann approved. So that was really something. I think the thing that I would want to say about that is that and not wanting her portrait done was in a way very much indicative of the fact that she didn't realize just how truly significant and how greatly admired she was. She underestimated the affection that people felt and held for her, the respect and regard people had for her, and the wealth of knowledge that she left with us. Her dedication and her advocacy and her very feisty spirit are unforgettable. She recognised that she was a leader, even despite the fact that she didn't realise just how truly exceptional her contributions were. And in that leadership role, she really took on a huge number of responsibilities. She was extraordinarily busy, but also extraordinarily productive. And I think it's a testimony to her that even now, nearly 25 years later, those of us who worked with her, when we see new ideas or when we're thinking about research concepts and the ways in which we might design our studies, we often say to each other, what would Ann have said in this situation? And I think that spirit of her inquiring mind and the fact that it lives on with us is one of her greatest legacies. Thank you very much.
Great. Thank you very much, Dr. Jenkins, for sharing your recollections of working with Dr. Woolcock personally, and just a remarkable life and legacy that is continues to this day. And we really appreciate also you joining us in the wee small hours of the morning in Australia, so that you could be here. So thank you.
Thank you, David.
And now I would like to introduce our speaker. Dr. Sarah Svenningsen is a Tier 2 Canada Research Chair in Translational Pulmonary Imaging and Assistant Professor of Medicine in the Division of Respirology at McMaster University. She's an affiliate scientist of the Firestone Institute for Respiratory Health and the Research Institute of St. Joe's Hamilton. She completed her bachelor's and then her PhD in medical biophysics at Western University under Grace Paraga, and then went on to McMaster University, where she completed a postdoc fellowship in complex airways disease. Her research focuses on the development and application of novel pulmonary CT and MRI measurements in order to better understand, evaluate, and manage complex airways diseases such as asthma and COPD. She's published seminal papers advancing our understanding of ventilation defects on hyperpolarized helium and xenon MRI, including some of my favorite papers, studies of the associations between CT mucus plugs, xenon ventilation defects, and their response to biologic therapies in asthma. I'm really looking forward to her talk today. And with that, it's my great privilege to introduce the winner of the 2024 ATS RSF Ann Woolcock Memorial Award, Dr. Sarah Svenningsen.
Thank you very much for that kind introduction, Dr. Mummy, and Dr. Jenkins for sharing those reflections of Dr. Woolcock's career and really emphasizing her truly immeasurable impact on the field of respiratory medicine. It's an absolute honor to be giving this webinar today and to have joined the list of distinguished recipients of the Ann Woolcock Memorial Award. You should be able to see my slides okay? David, could you just confirm? Great, thank you very much. Okay, so here are my disclosures. And as Dr. Mummy alluded to, my research is primarily focused on leveraging pulmonary imaging to better understand and treat asthma. And this will be the focus of my lecture today as I was asked to review some of my asthma research. And I felt that it would be quite important to start by acknowledging that Dr. Woolcock was truly a trailblazer in this field. She was among one of the first to leverage 3D pulmonary imaging to investigate and better understand asthma. And this is really a landmark study from 1997 that was published in the Blue Journal, where Dr. Woolcock and her team evaluated SPECT as a method to investigate airway closure for the first time. And the second line of this abstract states that Professor Woolcock felt that it would be important to find segmental areas of the lung that were affected by closure, as they would be important to our understanding of asthmatic airway function. And what this study ultimately showed was that SPECT is a valid method for measuring and visualizing airway closure in vivo. And then a year later, Dr. Woolcock and her team first described differences in airway closure between normal patients between normal individuals and patients with asthma as measured by SPECT. And what they observed was that in patients with asthma, the distribution of ventilation was more patchy, it was uneven, and that there were discrete wedge-shaped defects observed in some of the patients with asthma. And they ultimately hypothesized that this suggests that there may be closure occurring in the large airways of patients in asthma, and that these sites may represent airways occluded by mucus plugs, by constriction of the smooth muscle, or by structural changes in the airway. And it's quite interesting that 16 years later, as a graduate student under the supervision of Dr. Grace Periga, we revisited this hypothesis and asked the question, what are ventilation defects in asthma? And alongside my colleagues at McMaster and Western University, I've really spent the past decade trying to answer this question. And today, ventilation defects, or these regions of airway closure described by Professor Woolcock on SPECT, are now being used as endpoints in clinical trials and also to guide treatment decisions in asthma. So I'll take you on a bit of a data journey to where we are now and how far we've come from these initial 3D images of ventilation defects in asthma. So since the early 1990s, the in vivo asthma lung imaging arsenal has really expanded significantly with both quantitative CT and hyperpolarized gas MRI biomarkers now dominating the asthma literature. And very similar to Technegas SPECT that was used by Professor Woolcock in her two Blue Journal publications, xenon ventilation MRI provides us with a non-invasive, objective, and regional assessment of airflow obstruction in asthma. And I'm showing here a representative patient with severe asthma. The top panel is a coronal center slice image, and the bottom panel is a 3D reconstruction of this same information. These cyan regions here within the lung are ventilated lung regions, and the areas of signal void within the thoracic cavity are ventilation defects. And these are essentially areas of the lung that the xenon gas was unable to access when this patient took a breath in. And we can quantify these regions of signal void or these ventilation defects using a metric called the ventilation defect percentage, abbreviated VDP. It's very intuitive, and it's calculated as the ventilation defect volume. So the yellow regions within this 3D reconstruction normalized to the total lung volume. So for this representative patient with severe asthma, the VDP is 15%, indicating that 15% of the patient's lung isn't being ventilated. And quantitative CT provides us with complementary structural information. I'm showing here a parametric response map for this same patient with severe asthma, where these pink voxels represent gas-trapped lung on expiration, so regions of functional small airways disease. And the few yellow voxels you see here are representative of emphysematous tissue on inspiration. And as expected in this patient with severe asthma, we see very little emphysema, but extensive gas trapping indicating functional small airways disease that's really nicely correlated with the ventilation abnormalities we are observing on the xenon ventilation scan. We can also segment the airway tree to quantify CT visible airway structures related to asthma pathology. And then we can co-register the functional information provided by MRI. And what this allows us to do is to spatially relate structural abnormalities in the airway to ventilation defects within the lung, as shown here. Then we can measure the airway wall, we can measure the lumen area, and as this video here is showing, we can also identify complete occlusions of the airway lumen by mucus. So a really nice visualization of mucus plugging within the airway. So collectively, these modalities provide us with an objective in vivo assessment of airway structure and function. And the front end of my lectures is mostly going to focus on ventilation MRI. And on this slide, I'm showing ventilation MRIs for 4 representative patients with severe asthma. And the purpose of showing these cases is to really emphasize that the distribution of ventilation defects is variable between patients with asthma. They may be heterogeneously distributed throughout the lung, or they may be localized to a single lung lobe, and in some cases, a single bronchopulmonary segment. Additionally, I want to highlight that there can be a discordance between the FEV1, so our standard clinical measure of lung function, and then what we see with a functional imaging. And if we focus in on these first 2 cases here, I'll highlight that they both have a normal FEV1 of 95% predicted, but I think you would agree that there's a strikingly different and abnormal ventilation patterns in both of these cases. So ventilation defects, they're regionally heterogeneous, they're patient-specific, and they're providing us with additional information that's not offered by current clinical measures of airflow obstruction, such as FEV1. And ventilation MRI is also highly sensitive to changes in airway patency. This is the same subject with asthma imaged at baseline after a 20% fall in FEV1 induced by methacholine, and then after salbutamol rescue. And what you can see here is this dramatic decrease in ventilation localized to the lower lobes, and then that's largely reversed with bronchodilation. And this burden of ventilation defects, which I introduced, can be quantified as the ventilation defect percentage, has been associated with asthma severity, asthma control, severe outcomes, including ED visits and hospitalizations, also exacerbations. And what this data collectively suggests is that what we're able to visualize and quantify with MRI is important to the asthma patient. So over the next 10 minutes or so, I'll walk you through a series of studies that we completed in patients with asthma that really start to answer the question, what are ventilation defects in asthma? And they collectively establish the sensitivity of ventilation MRI to key components of asthma pathology, some of which we've heard about in Dr. Jenkins' introduction, including smooth muscle dysfunction, mucus within the airway lumen, and then inflammatory cells within the airway lumen. So to get at this question, we first initiated a study to investigate the contribution of airway eosinophils and smooth muscle dysfunction to luminal obstruction, resulting in MRI ventilation defects. So we enrolled about 30 patients into this study, and they underwent pre and post bronchodilator ventilation MRI to assess bronchodilator responsiveness of ventilation defects. And this was an indirect measure of smooth muscle dysfunction. And then to assess airway eosinophils, all of these patients had performed a sputum induction, and we quantified the percentage of eosinophils within the airway. And these patients were then dichotomized based on the percentage of eosinophils in sputum to those who had controlled eosinophilic bronchitis and those who had uncontrolled eosinophilic bronchitis. And shown here is a representative patient with asthma from this study who had controlled eosinophilic bronchitis, so they had 1% eosinophils in their sputum. We can see here pre-bronchodilator, these numerous ventilation defects distributed throughout the lung. And I'll highlight or emphasize here that this patient has a completely normal airflow obstruction assessed by FEV1. Following bronchodilator, the ventilation in this patient was completely normalized. So all of these ventilation defects were resolved. And this is another case now showing a patient with asthma with uncontrolled eosinophilic bronchitis. So 42% of eosinophils were observed in this patient's sputum. Again, we can observe these focal regions of ventilation defects pre-bronchodilator. And following bronchodilator, we saw a subset of those ventilation defects improve. But what was most striking at the time of this study was these persistent ventilation defects that I've highlighted here in yellow. So for this patient with whose inflammation wasn't controlled, residual ventilation abnormalities were observed post bronchodilator. And this is the quantitative data for all patients in this study. So we have the MRI VDP on the y-axis, our uncontrolled eosinophilic bronchitis group, and our controlled group, and then the pre and post bronchodilator VDP measurements. What we observed was that the VDP was elevated but not different between these two groups pre-bronchodilator. The MRI VDP was improved post-bronchodilator in both groups, indicating smooth muscle response. But then again, really the key observation here was that there was significantly more residual ventilation defects observed in that group with eosinophilic bronchitis. So this suggests that these fixed ventilation defects that we were observing post-bronchodilator may be due to the inadequate control of eosinophils that were consequently plugging the airway lumen. And to lend further support to this notion, I'm showing here post-bronchodilator that there was a significant positive correlation between higher VDP and more eosinophils within the airway. So at this time, we thought that if ventilation defects that persist following bronchodilator are indeed the functional consequence of eosinophils in the airway, then patency and airflow should certainly be restored if we can reduce or normalize the level of eosinophils within the airway. So to address this hypothesis, we initiated an extension study. And what we did here is we took those patients who had uncontrolled eosinophilic bronchitis at the time of imaging. They then had an increase in their anti-T2 therapy in the form of anti-T2 biologics or prednisone. And then we brought them back when their sputum eosinophils normalized. And at that time, we repeated both the pre and post bronchodilator imaging. And so I'll take you back to the patient 2 that I had shown on the previous slide. I'll remind you that this patient had uncontrolled eosinophilic bronchitis at baseline, and we observed these persistent ventilation defects despite a bronchodilator. And benralizumab ultimately normalized the eosinophils in this patient's sputum. And at that time, we repeated imaging. And what this revealed was that those bronchodilator non-responsive ventilation defects were resolved. So we think what we're visualizing here is the functional consequence of clearing eosinophils that were plugging this patient's airway lumen in that focal lung region. And this box and whisker plot shows the MRI-VDP pre and post bronchodilator at baseline and following anti-T2 therapy that controlled the airway eosinophilia. And you'll see that the VDP was significantly improved with anti-T2 therapy, and that was measured both pre and post bronchodilator. And both at baseline and post anti-T2 therapy, we still observed a significant improvement in ventilation following bronchodilator. And this slide summarizes the same data, but for all 10 patients that we evaluated in this study. And really the message that I want to highlight with this slide is that in a subset of patients, focal ventilation defects were non-responsive to therapy that was directed at both T2 inflammation and smooth muscle dysfunction. And this isn't at all surprising, as we know there are other cells and pathology that may be important to airflow obstruction in asthma. And in reality, there are 4 well-recognized airway inflammatory phenotypes of severe asthma that can be identified by sputum cytology. So we had just discussed the polygranulocytic and the eosinophilic phenotype, but there's also the neutrophilic and mixed granulocytic phenotypes. So we then applied xenon MRI to characterize the ventilation defect burden in these specific sputum cellular phenotypes of severe asthma. So what I'm showing here now on this slide is pre and post bronchodilator xenon ventilation MRI scans for a representative patient with polygranulocytic, eosinophilic, neutrophilic, and mixed granulocytic sputum on the same day that we performed imaging. And compared to a healthy control cohort, the post-bronchodilator MRI-VDP, which I'm showing here on the y-axis, was not significantly different in those patients with asthma with polygranulocytic sputum. But in those patients with eosinophilic, neutrophilic, and mixed granulocytic sputum, the post-bronchodilator MRI-VDP was significantly elevated. So what this data tells us is that ventilation is abnormal in the presence of intraluminal cellular inflammation, really irrespective of the phenotype. And very similar to how cells may obstruct the airway lumen, mucus plugging is also a key and in my opinion, a really dominant contributor to ventilation defects in patients with severe asthma. On the left here are postmortem mucus plugs in a case of fatal asthma. This is from a 1959 publication by Dunnell. And on the right here is an H&E stained mucus plug in asthma, and really an exquisite spatial single cell characterization of a mucus plug and the airway assessed by or imaging with mass cytometry. And these are images from Tilly Hackett and John Fahey that were just published a few days ago in this JCI manuscript that I would encourage you to have a look at. But as I alluded to earlier, with CT, we have this ability to visualize mucus plugs in vivo. And this is a representative patient with severe asthma, where we identified a mucus plug on CT in the medial basal segmental airway. And then by performing ventilation imaging on this patient, we can see the functional consequence of that mucus plug. So here I'm showing the pre and post bronchodilator ventilation MRI, and you can really see the detrimental consequence of a single mucus plug that's occluding a segmental airway. And we then had our radiologists generate the CT mucus score according to a method that was developed by Eleanor Dunnican and was reported for the first time in a JCI publication from 2018. And we quantified the burden of mucus using the CT mucus score to evaluate the relationship between mucus plugging and abnormal ventilation observed by MRI. And what these plots show is that patients with asthma with a high CT mucus score have significantly higher or worse VDP compared to those patients with a lower CT mucus score. And we also observed a quite strong correlation between the MRI VDP and the CT mucus score. And to better understand the independent or combined influence of mucus and eosinophils on ventilation, we then classified asthmatics based on these contributors to luminal plugging, so both the CT mucus score and sputum eosinophils. And if I flip through here, when we look at the MRI VDP for those patients, what we observed was that the MRI VDP is increased in patients with mucus, both without eosinophils, and it's further increased in those patients with both elevated eosinophils and mucus plugging. And in this multivariate linear regression model, both mucus and eosinophils independently contributed to reduce lung function quantified by the MRI VDP. Okay, so those 4 studies that I just presented to you were really quite hypothesis driven. In an independent sample of 75 patients with severe asthma, a graduate student of mine, Ashutosh Thakkar, led an analysis to try to identify ventilation phenotypes of severe asthma, but this time using an unsupervised clustering approach, and then to examine their demographic, their clinical, their physiological, and inflammatory characteristics. And each row in this heat map here represents a patient with severe asthma, and each column is a Z-score of their MRI ventilation, of their xenon ventilation MRI feature. So in this study, we went beyond just using the VDP, which I've been discussing with you. We also quantified the size of these defects and then various features of the ventilation signal itself. And what unbiased analysis of this data identified was 3 distinct ventilation phenotypes of severe asthma. Phenotype 1 was the smallest group of patients, and this was 13% of our cohort. They had normal to near normal ventilation. Phenotype 2 consisted of over half of our patients, and these asthmatics had markedly abnormal ventilation. And then phenotype 3 consisted of about 32% of our cohort, and they had severely abnormal ventilation. So they had these large ventilation defect regions. But what was quite interesting is that despite these substantial differences in the ventilation heterogeneity, the reported asthma control, their quality of life, their dosage of medications, biomarkers of T2 high asthma, and their biologic use did not differ between these phenotypes. So they were really reporting had a similar clinical disease burden. But they were significantly different with respect to their demographics, their lung function, their inflammatory biomarkers, and their CT measurements. And I'll highlight some of this data. So phenotype 1 had a high prevalence of young females. It was 80% female. 60% of them were obese. They had frequent masqueraders of asthma, and they also had a low total lung volume. Phenotype 2 was a gender balanced cohort with 56% were obese, and they had a history of cardiovascular disease. And then phenotype 3 was an older gender balanced cohort. They were of normal weight, and they had a history of recurrent chest infections. And we also observed a stepwise upwards burden of gas trapping, so functional small airways disease, and mucus plugging on CT as we moved from phenotype 1 to phenotype 3. Also, there was a higher prevalence of airway inflammation assessed by sputum in those patients in phenotype 2 and phenotype 3. So 80% of those patients in phenotype 1 had paucigranulocytic sputum. So this discordance in ventilation between phenotypes and their clinical characteristics was quite interesting, and perhaps suggests different mechanisms that may be driving severe asthma that may be addressed with personalized and precision clinical management. Okay, so these studies that I've highlighted up to this point really have brought us a long way in understanding what ventilation defects are in asthma. And they really align with Professor Woolcock's initial hypothesis here. We observed relationships with smooth muscle dysfunction, mucus in the airway lumen, also cells within the airway lumen. And with this understanding, there's now an opportunity to apply a ventilation MRI alongside quantitative CT to evaluate treatment response and better understand mechanisms of treatment response, and perhaps ultimately to inform treatment decisions. So in the last 10 minutes or so, I'll walk you through two studies that highlight how we're doing this, starting with the use of imaging endpoints in a clinical trial of dupilumab to better understand the mechanism of clinical benefit. So very briefly, dupilumab is a monoclonal antibody that targets the IL-4 receptor alpha. It blocks signaling of both IL-4 and IL-13. It's been shown to improve asthma outcomes. And the clinical benefit of IL-4 receptor antagonism is likely due to the reduction of characteristic features of IL-4 and IL-13 signaling. So this includes airway smooth muscle contractility, remodeling, recruitment of eosinophils to the airway, also mucus production. And at the time of us designing this trial, there was really no published evidence to support this mechanism of clinical benefit in patients with asthma. So we designed a trial to evaluate the effect of dupilumab on airway hyperresponsiveness, eosinophilia, mucus plugging, airway remodeling, and then ultimately their functional consequence on ventilation assessed by MRI. But for the purpose of this presentation, I'm solely going to focus on our imaging endpoints. So again, very briefly, this was a single center randomized double-blind placebo-controlled trial. We evaluated adults with uncontrolled moderate to severe asthma. They had evidence of current airway hyperresponsiveness and a T2 immune signature. Patients were randomly assigned at a 1-to-1 ratio to receive dupilumab or matching placebo every 2 weeks for 16 weeks. Now, we performed both CT and MRI at baseline and at week 16 in this study. And we ended up with 13 patients who completed the trial who received dupilumab and 11 who received placebo. So a relatively small trial. And the key imaging outcomes that we were interested in to assess large airway morphology was mucus plugging, the wall area percentage, and the lumen area. And we assessed mucus plugging using the CT mucus score that I mentioned earlier that was developed by Eleanor Dunnican and first published in 2018. And essentially what we observed was that following 16 weeks of dupilumab, there was a reduction in the CT mucus score, and this reduction was greater than what we observed in the placebo group. And on the bottom here, I'm showing a few representative airways before and after dupilumab treatment. And you can see that airways occluded by mucus were patent following dupilumab. We also observed that there was a reduction in the wall area percentage and an increase in the lumen area following 16 weeks of treatment with dupilumab. So what this data told us or shows is that dupilumab is able to modify large airway patency over a relatively short period of time. And then we asked the question, what is the consequence of this on airway function? And to address this, we evaluated ventilation assessed by the Xenon MRI ventilation defect percentage and gas trapping assessed by the low attenuation area less than -856 Hounsfield units. And what we observed following 16 weeks of dupilumab, there was a reduction in the MRI VDP, and there was a reduction in the gas trapping, and this reduction was greater with dupilumab when compared to placebo. But really, this slide will emphasize the power of structure function imaging and how we can really get at the mechanism of improvement in airflow obstruction with these biologics. So this is a representative case at baseline, the pre and post bronchodilator ventilation scan. We can see this large ventilation defect that's not improving with bronchodilator. And what we observe on CT is a completely occluded segmental airway that's spatially related to that ventilation defect. And following dupilumab, that mucus plug was cleared, and we can very nicely visualize the consequence of that on lung function, where we can see ventilation being restored to that right upper lobe. And in all patients in this study, we observed that the change or the improvement, the reduction in mucus plugging was correlated with improvement in ventilation. So to conclude this trial, quantitative CT revealed that dupilumab was able to modify large airway patency. It reduced the mucus plugging, it decreased wall area percentage, and increased the lumen area. And the functional consequence of dupilumab on improved airflow was confirmed by a reduction in gas trapping and an improvement in ventilation. And that reduction in VDP with dupilumab was correlated with the reduction in mucus. I do very quickly want to acknowledge that other biologic treatments that block T2 cytokines and mediators can reduce mucus plugs observed on CT in patients with severe asthma. The Vestige trial was published just a few weeks ago in Lancet Respiratory Medicine. And this reproduced our observations of dupilumab reducing mucus. Of course, this was a larger multi-center RCT. And there's also been a randomized controlled trial that showed that tezepelumab can reduce mucus plugging observed on CT. And there have been two uncontrolled single center studies reporting that benralizumab can also reduce mucus plugging. So as a follow-up to the dupilumab RCTs, which again showed a reduction in mucus, a graduate student of mine, Akam Sandhu, completed a retrospective analysis to further characterize the effect of dupilumab on the spatial and temporal behavior of mucus plugs. So he completely annotated all plugs visualized on CT at week 0 and week 16 to determine the total mucus plug count and then the temporal and spatial behavior of individual mucus plugs. So I'm showing here 3D renderings of these annotations with CT identified mucus plugs shown in red for a patient with dupilumab. We can see a reduction in the total number of mucus plugs, and a patient who received placebo. And essentially what this plot is showing here is that following dupilumab, there was a reduction in the total mucus plug count, and this wasn't observed in the placebo arm. But what we characterized then was the temporal behavior of individual mucus plugs. And we characterize them as resolved plugs, as fixed location persistent plugs, and as new onset plugs. And what we observed was that 90% of all mucus plugs observed at baseline were resolved, and 10% of mucus plugs were fixed following 16 weeks of dupilumab. And there were fewer resolved plugs, and there were more fixed location plugs in the placebo group. And then the number of new onset plugs was lower following dupilumab compared to placebo. And then ultimately, we can characterize the change in the burden of mucus at 16 weeks, and that's summarized here by this Sankey plot. So of the patients who were treated with dupilumab, 36% of those patients had a complete resolution of their mucus plugs, while 59% had persistent plugs, and 5%, or one patient in this trial, had persistently no plugs over the 16 weeks. And then we're quite confident that those persistent plugs following dupilumab are functionally relevant. What this plot shows is the post-dupilumab MRI-VDP, and those patients with persistent plugs at the end of trial had a worse ventilation than those with a complete resolution of mucus. So what this retrospective analysis added is that it told us, or it tells us, that dupilumab can reduce persistent plugs, it can decrease the formation of new plugs, and it can completely resolve CT-evaluated mucus plugs in a subset of patients. And I'll remind you that this was over a short 16-week period of time. Okay, finally, and very quickly, I want to briefly introduce or highlight MRI-guided bronchial thermoplasty as a proof of concept for how regional information from pulmonary imaging can inform and guide treatment decisions in severe asthma, as there are now two published pilot RCTs to establish its safety and efficacy in patients with severe asthma. And to remind you, bronchial thermoplasty is a non-pharmacological procedure. It was developed for the treatment of severe asthma and to specifically target the airway smooth muscle component through local delivery of RF energy to the walls of the airways that are accessible by a bronchoscope. And this is generally performed over 3 bronchoscopy sessions to treat all accessible airways. And we designed a small 1-year pilot pilot RCT to evaluate MRI-guided versus standard whole lung treatment with bronchial thermoplasty. And our objective was to demonstrate that if we guide BT by the MRI, we're able to reduce the number of treatment activations, and that this will result in improved asthma control and quality of life scores that are non-inferior to those that can be achieved by treating the whole lung. So this was a small study. We randomized 14 patients with severe asthma who were clinically eligible to receive BT. All of the patients underwent hyperpolarized gas MRI, pre and post bronchodilator to characterize the ventilation defects, and they were subsequently randomized to MRI-guided or standard BT. And the participants randomized to standard BT underwent 3 bronchoscopy sessions to treat all accessible airways. But those patients who were randomized to MRI-guided BT, we selectively treated only those airways that were spatially related to ventilation defects and avoided treating those airways that were spatially related to functioning lung. So what did we observe? What this slide summarizes is that MRI-guided BT, which I'm showing here in maroon, resulted in 53% fewer radiofrequency activations and fewer bronchoscopy sessions than standard whole lung treatment. And despite the reduced number of BT activations and bronchoscopy sessions in that MRI-guided group, again, which I'm showing here in maroon, at 12 months, we observed statistically significant improvements in the Asthma Quality of Life Questionnaire score and the Asthma Control Questionnaire score in those patients who received MRI-guided BT. And if we consider the minimum clinically important difference for both of these scores, 4 out of the 5 patients who completed the 12-month follow-up had clinically relevant improvements at out to 12 months. And importantly, these improvements were not different or non-inferior to those who received whole lung treatment. And there was actually a trend towards those patients who had MRI-guided BT doing slightly better. So collectively, what these studies show is that one BT treatment session guided by MRI can achieve similar quality of life and control improvements compared to whole lung treatment, with the advantages of having a reduced procedure time and cost, also fewer adverse events. Okay, I will very quickly end with a few concluding points. Quantitative CT and xenon ventilation MRI are complementary modalities. They provide a sensitive, objective, and non-invasive measures of airway structure and function. Ventilation defects in asthma, which I focused quite a lot on today, can be directly visualized by xenon MRI and quantified as the ventilation defect percentage. These defects identify functionally relevant asthma pathology, and they indicate local obstruction due to smooth muscle dysfunction, airway inflammation, and mucus plugging. These defects are responsive to treatment. I highlighted two studies that showed reducing airway eosinophils and reducing mucus plugging with anti-T2 biologics reduces VDP in severe asthma. And our data also suggests that treating airways associated with ventilation defects improves symptoms and control. And this was demonstrated in a small proof of concept RCT of MRI-guided BT. So where are we now? Quantitative CT and xenon MRI measurements are being utilized for gaining a deeper understanding of asthma pathophysiology in clinical research. And this has really been the case and has increased exponentially since the seminal work from Dr. Woolcock with SPECT in the mid to late 1990s. But really, the recent shift is that these measurements are now starting to make their way as inclusion criteria in clinical trials and endpoints in clinical trials of asthma treatments. And some centers are starting to utilize these modalities and measurements for personalized clinical management of severe asthma. And I'll end by acknowledging my colleagues, my collaborators, and my mentors who contributed to the work that I've presented today. Most importantly, Dr. Grace Periga from Western University and Dr. Param Nair from McMaster University. Thank you very much, and I hope we have some time for a few questions.
Great. Thank you, Dr. Svenningsen. That was an absolute tour de force. While we're waiting for any questions in the chat, please drop them in. I'll take advantage of the moderator's prerogative and ask you one. So you mentioned the intersection between neutrophils and eosinophils in the different classifiers. And I admit I haven't really thought much about neutrophils in asthma. Is there, are there similar roles for targeted therapies? Do neutrophils also play a role in mucus plugs? What are your thoughts on where that's going to go?
Yeah, I don't think we have strong evidence yet to, for me to respond to that. I think certainly what our data suggests is that there is mucus plugging in these patients with neutrophils in the airway. And the paper actually that I highlighted from Tilly Hackett and John Fahey actually provides some nice novel mechanisms into that, showing that there's eosinophils and neutrophils in some of these plugs. So what our data shows is that, I think both neutrophils and eosinophils can contribute to abnormal ventilation. And similar to what we've observed in our anti-T2 trials, if we're able to treat the neutrophilic bronchitis, my hypothesis is that we would be able to restore some ventilation due to those due to the neutrophilia.
It'll be interesting to see how it seems like we're kind of overlapping with some mechanisms of COPD bronchitis as well. It'll be interesting to see how that goes.
There is a question in the chat from Marcelo Menezes. He thanks you for the brilliant talk and asks, in the long run, do you think that in the long run, optimization of inhaled anti-inflammatory would have similar effects as anti-T2 biologics? Was that assessed?
Yeah, again, I think I can only speak to the data that we have, and most of our work shows that a lot of the data was in patients with severe asthma, so they were on high-dose ICS, and there was residual, eosinophilic inflammation and functionally relevant ventilation defects in those patients who were on high-dose ICS and optimized therapy. And they did require anti-T2 biologics to normalize the eosinophils within the airway, and then the result of that was an improvement in ventilation.
I actually have a question. As a clinician, the question I have is about performing the MRI itself. While recruiting patients and doing the study, what are the challenges you face in terms of doing the test? Duration, claustrophobia, were there challenges?
No, I appreciate that question because it's something I didn't touch on in my talk. And we're now at a point where this type of imaging, so xenon ventilation MRI, has been FDA approved in the United States, and it's now being used clinically in some cases in some centers that have these capabilities. And from my experience of doing this primarily in clinical research, imaging well over 300 patients with asthma, there has been, I think, one patient out of all of those who haven't been able to tolerate this type of imaging. So the success rate is quite high.
Thank you. There's a question from Ming Chow. He asks, for the image-guided BT, you are assuming one-time imaging will identify the area needed to be treated. Is that a valid assumption?
Yeah, so, and I didn't get into detail of how this, the study design actually worked in that. What we did was we ensured the patients were optimized with respect to their corticosteroid therapy. So these patients all had the inflammatory component of their disease had been normalized or controlled with treatment. And then these patients had persistent defects after that were responsive to a bronchodilator or that appeared following a methacholine challenge. So we were confident that those ventilation defects that we were then using to target had characteristics of smooth muscle dysfunction. I hope that gets at that question.
All right, we should probably wrap it up there. Thanks to our ATS RSF hosts. Thanks for everyone who stayed a few minutes over for Q&A, and most of all, thanks Sarah for the tour de force of a presentation. That was really fantastic.
Thank you very much.
Thanks, everyone.